And hello, everyone. My name is Mark Blythe. I am the director of the Rhodes Centre for International Economics and Finance at the Watson Institute at Brown University. I'm delighted to have with me today, as one of our events, a discussion of Luc Messac's new book, No More to Spend: Neglect and the Construction of Scarcity in Malawi's History of Healthcare. I'll tell you a little bit about Luc in a second, and then he can take it away and do the talk. Some logistics as to how we're going to run this. It's 1 hour. I think we're all settling on a common model for how we do these things now. I'm going to shut up very quickly and then pass it on to Luc. At that point in time, if you want to ask questions for the Q&A section, which we'll get to around 35 minutes, please, if you're on Zoom, just type them straight into the Q&A. If you're watching this on YouTube and you want to ask a question, type it into the comments on YouTube, and we have someone who's monitoring that. They will put them into our Q&A, and that's how we'll do the Q&A. Just a quick word of introduction on this. Luc and I got to know each other very recently. He reached out to me in terms of the directorship of the centre and centre events. And I saw something about his book in the Brown News that goes around in the morning. And I got really interested in this, very sort of selfishly, I guess. So a couple of years ago, I did a book called Austerity, The History of a Dangerous Idea, which essentially claims in some way the same thing as Luc, that scarcity is a fact, but it's also a socially contingent fact. And that means that there's a lot of wiggle room and a lot of politics around what is necessary and what is not. So I got a hold of the book, and it's great. So I'm just going to pass it over now with a little further introduction on Luc here. Luc is a physician and a historian. His research focuses on the histories of health financing and medical practice in Southern Africa and the United States. He's currently senior resident in emergency medicine at Brown University. He received his BA from Harvard and his MD and PhD in history and sociology of science from the University of Pennsylvania. And again, the book we're about to talk about was published earlier this year, No More to Spend: Neglect and the Social Construction of Scarcity in Malawi's History of Medicine. Luc, take it away.
Mark, thanks so much. I've been inspired by Mark's work for years, so it's a real honor to be here. And thanks to all my family and friends who are here already. Looking forward to the talk. So I'm going to share my screen here, and then I do have a few slides. Let's start in Malawi. This is a place I got to know really well over the last decade or so of work. And, first I want to say that I spent a lot of time in people's homes, and I was invited into their homes, their lives, their hospitals. And I got to know the most intimate details of their lives. And I'm just very grateful to all of them for trusting me and trusting me with this information. I spent time in the archives, digging through, dusty shelves full of termites to try to get more of the story as well. And it did uncover some really interesting and kind of surprising things about how our understanding of healthcare in poor countries can be at times impoverished and needs to be revisited. One of the questions I wanted to ask in the course of talking to people and learning about their lives was, how has debt been used to delay or deny healthcare? Do theories of development like modernization affect healthcare spending? And how do war, unrest, diplomatic struggles, and activism influence the availability of healthcare? These are the kinds of questions that came up in the course of living with people, hearing their stories, and learning more of the history of Malawi. So Malawi is a beautiful and interesting place. It's not a place that I imagine a lot of folks have been to before. So just by way of introduction, it's a small landlocked country about the size of Pennsylvania, and it's landlocked in southeastern Africa. Between the 1890s and the 1960s, it was a British colony, and then more recently, it's been an independent country. And I want to take you first into the life of a young boy named Innocent. Innocent was coming home from school one day when he happened across a protest, and the protest was about land alienation. The government was planning to move an entire village in order to make room for a resort for a multinational company. And during the protests against this move, there was the police opened fire on the protesters, and Innocent, while walking home, came across this and was shot through the leg. Unfortunately for him, the bullet pierced his popliteal artery, one of the main arteries supplying blood to the lower leg. And when he was brought to the district hospital nearby, there was no vascular surgeon available to perform the surgery that he would need in order to save his leg, a vein graft surgery that's very common in the United States, but unavailable in Malawi because there are no vascular surgeons in Malawi. So over the course of the next 2 weeks, I went to visit Innocent a few times, and I saw that first his toes turned this ghostly hue, and then his toes began to blacken, and then the gangrene set in and started to rise up his leg. And in order to save his life, prevent him from developing an overwhelming infection, the surgeons in the hospital took him and amputated his leg. This was obviously a traumatic experience for him, but even more so because he was too poor to even afford a prosthetic, and it was unclear how this son of subsistence farmers would be able to live his life afterward. And one of the questions that came from this experience for me was this inevitable? Was this something that had to happen? Was he fated to suffer this fate because he was a poor boy living in a poor country? Or was there more to the story? Was the scarcity he was living in, the scarcity in which there were no vascular surgeons available, was that inevitable, or was there a construction there? Was there something that could have been done? Might it have been otherwise? And looking at Malawi's history, we see that the availability of healthcare spending, or the amount of healthcare spending, has always been pretty low. This graph is of healthcare expenditure in Malawi in constant pound sterling. So just multiply it by about 1.3 to get dollars. And you see that it was never higher than 8. It was actually highest in the 1960s. And even today, or most recently in 2017, Malawi had $32 per person per year of healthcare spending, while the United States had $10,000. So where did this start? When we can start many places, but let me just take you back to World War I. It's a time we're actually talking about a lot these days because of the 1918 flu pandemic, which has echoes in our own age, but there's another place where we have echoes, and that's in World War I. And World War I was fought not only in France, but also in East Africa. The British and the Germans fought in what is today Tanzania and Malawi. And in order to bring their munitions and supplies and mail and alcohol to the front, the British and the Germans kidnapped people from their homes and impressed them into service, in order mostly to serve as carriers, to literally carry on their backs and on their heads the supplies that would be needed to fight the war. Hundreds of thousands of men, women, and children were impressed as carriers. Many died of dysentery, cholera, exhaustion, exposure. And you'll see from this quote from a British convoy officer that the carriers really had no dog in the fight. They had no interest in who won this war. Their only interest was in staying alive. And in the course of the war, there was much suffering, but one of the things that actually came of the war, that really was the only thing that most Malawians said after the war was worth keeping, were these carrier hospitals. The British in particular had set up a few thatch-roofed hospitals, such as they were, where nuns and other religious usually would provide some modicum of care to the carriers. And while the care wasn't very good and very well resourced, it was one of the few things that Malawians said was worth keeping after the war. So after some delay, the British actually did set up a system of dispensaries, these small, poorly resourced dispensaries around the country. And one of the things that existed at the time also was this thought in development thinking that health, better health, could bring more wealth, could bring more productivity. You see this in the quote here from Herbrand Sackville, kind of insulting as it is. It does impart this idea that healthcare could increase the productivity of the native population. But during the decades that followed, aside from these dispensaries, not much was done to improve the health of the population. And while Malawi remained a poor backwater of the colonial empire, it's not at all clear that this poor spending was inevitable. And in fact, when you look at what money was spent on, you'll see that money was spent in a pretty illogical way. There was a railway that was built between what is now Malawi and the ocean. And you remember from the map that Malawi is a landlocked country. So in some ways, it makes a lot of sense. Why not build a railway to get exports to the broader world? The problem was that this railway was built in such a way through a circuitous route that made very little economic sense. So much so that the railway never turned a profit, and it was never worthwhile for people to send their products to export via this route. And the reason why it was built this way is because a financier named Libert Uri, this guy from Belgium, who had a lot of connections in the UK, convinced the UK to take on a loan to build the railway and to saddle the repayment of this loan on the government of Malawi, and therefore on the taxpayers, the native population of Malawi. And not only did Libert Uri get this loan, but he was guaranteed a profit. He was guaranteed a 7% or 6% profit for 25 years. And because the railway failed immediately, that ended up being the responsibility of the native population. And so they ended up spending half of their budget every year just on this railway, while they spent less than 6% of their budget on healthcare. A little later, you started to see this huge rise in people coming to the hospitals, people coming to the dispensaries. And it wasn't that these hospitals and dispensaries were getting all that much better or that the population was growing, but what you did see was new medications coming in. Penicillin, new medications for tuberculosis like streptomycin, new medications for malaria like chloroquine, made it possible for even these poorly resourced health centers to cure disease, to make people feel, to cure people, to make them better. And as a result, you saw people coming to the hospitals in droves. Now, there was more health spending during this time. And one of the things I was interested in is, why did this happen? And if you look to development theory at the time, whereas in the 1920s, 1930s, people were interested in tropical medicine, people were interested in the increase in productivity that healthcare spending might bring about. By the 1950s, 1960s, that actually had changed to the point where people like W. Arthur Lewis, an important modernization theorist, a developmental economist, they were saying that the opposite was true, that health spending was consumption, not investment, and wouldn't improve overall productivity of the population. But it was during this time that you saw more spending on healthcare. You remember that graph? It was one of the peaks, such as they were, more spending in relative terms during the 1950s, 1960s. And I was interested, why did this happen? Part of the reason why it happened is because there was more protest during this period. This was a period of tremendous unrest. During the 1950s and 1960s, Malawi's government was handed over from the British officials in London to settlers in what is today Southern Rhodesia. And if you'll remember, Southern Rhodesia was the inspiration for Dylan Roof when he shot up a a congregation in South Carolina, in a Black church in South Carolina. It was, in the history of the late 20th century, one of the most avowedly white supremacist governments we've ever seen. So while the Southern Rhodesians promised the British that their government would be a partnership between whites and Blacks, when Godfrey Huggins, the Prime Minister of Southern Rhodesia, spoke to his closest supporters, his closest white settler supporters, he said the partnership would be that could be likened between a partnership between a rider and his horse. But because of the protests against this regime, because Malawians were so opposed to rule by Southern Rhodesia, there was a crisis of legitimacy. And as a result, Huggins and his government started spending more on healthcare than had ever been spent before. They built hospitals, they built clinics, they got more resources. Nevertheless, the hospitals were still segregated. You'll see here a picture of the African hospital. They were often situated at the bottom of, the lowest level of elevation in a community, whereas the white hospitals would be situated kind of at the top of a hill, in order to just show you how much care was devoted to either one. Eventually, Malawi gained its independence. In 1964, Malawi became an independent country, and its first leader was this doctor, actually, named Hastings Kamuzu Banda. Banda was a really interesting figure. He was born in poverty in Malawi in the early 1900s, and then was kicked out of a mission school, supposedly for cheating. He went to South Africa, where he became a hospital orderly, a janitor in a hospital in South Africa, and then found his way into a scholarship in the United States. He went to the University of Indiana, and then he went to medical college at Meharry Medical College in Tennessee, found his way to London as a general practitioner, and then to Ghana, and then finally back to Malawi as what was supposed to be kind of a figurehead of the independence movement. But when independence came, he consolidated control and became the then president for life, as he called himself, for the next 30 years. Now, you'd think that a Black Malawian doctor, one of the few in the country, would make healthcare spending, or healthcare in general, a priority of his rule. But he didn't. He, in fact, spent more money trying to move the capital into his own home district. He spent lots of money on palaces. One of the political prisoners under his rule was a famous Malawian poet named Jack Mapanje, who said that he spent more on prisons than he did on hospitals. And so there was relatively little focus on healthcare during his rule, despite the pictures like this that he often took during his Christmas pilgrimages to hospitals to visit patients. But one of the things he did do was he used his diplomatic position to garner some resources for health. So while he didn't spend much on health, while he didn't make it a focus, he knew he had to do something. And so he would convince governments in the area to support his healthcare sector. And one of the things that he was known for was that Malawi, under his rule, was allied with some of the white supremacist governments in the region, with Southern Rhodesia, with apartheid South Africa, with Portuguese Mozambique. And he used these connections to get some healthcare funding. So he made this example. When he wanted to build a new hospital in Dedza, he asked a foundation that was allied with the Portuguese government, which still ruled Mozambique as a colony. He asked them for funding, and he said, in return for my loyalty to you, for my support for you and the UN and other bodies, give me some funding for building this hospital in Dedza. And he bragged about this when he opened the hospital. So while there wasn't much spending on healthcare, he did make use of these diplomatic connections. But make no mistake, this was a dismal time for healthcare, and it would only get worse. In the 1980s and 1990s, Malawi became one of the epicenters of the AIDS pandemic. People died in droves and in misery. The hospitals were overwhelmed. And doctors and nurses wrote about the conditions, saying that they were without anything they would need to provide a modicum of care for their floods of patients. And at the same time, development thinking, some of it supported healthcare spending, but some of it actually made the AIDS epidemic sound like an economic boon. There's this paper from the Quarterly Journal of Economics, a pretty important journal in economics from 2005, in which a professor at the London School of Economics said that the AIDS epidemic would actually increase per capita income in South Africa, which was also being affected by the pandemic. In part, he said, because fertility rates would go down and there'd be more available for those who survived. And he called this the gift of the dying. So this was the kind of thinking that was going on in development circles at the time. And one would think that with that would come an inattention to the AIDS epidemic. But actually, this was the moment when healthcare spending, when healthcare, specifically foreign aid for health, rose precipitously. And part of this came because of international activism. Al Gore at the time was trying to get the South African government to stop importing generic AIDS drugs from other countries, from India in particular. And the United States was threatening South Africa with trade sanctions if they refused to comply. But Nelson Mandela, the president of South Africa at the time, was obstinate in his refusal to stop. They continued to import generic AIDS drugs, and a part of this was due to a very active and vocal AIDS activist community in South Africa, led by Zaki Yakmat, who you'll see here standing with Nelson Mandela, that helped spur this move towards greater attention to the AIDS pandemic. And you'll see that as a result of these moves by activists, the price of AIDS drugs dropped precipitously during this period and made it possible to treat AIDS on a global scale. Healthcare spending, development assistance for health, which you'll see in this graph, so foreign aid for health, rose precipitously during this period, and it made it possible to have what we have in Malawi today, where the vast majority of people living with HIV in Malawi are on antiretroviral therapy, are on life-saving drugs. But now we reach the present. Back in the present, where as a result of the coronavirus epidemic, there's actually relatively little in the way of cases of coronavirus that we know of in Malawi, although testing capacity is limited. But because of the shutdowns and the loss of exports and the absence of stimulus spending, I mean, think about the fact that more than 90% of global stimulus spending for the coronavirus epidemic has been spent in rich countries. Malawians are really suffering. Their healthcare spending, the healthcare system is suffering. And many of my friends, the people who I lived with before, have talked about the extent of hunger and where they live. So it's a perfect time perhaps to think again about what kinds of scarcity we live with and whether they're necessary. Do we have to accept the fact that still Malawi lives with $30 of healthcare spending per patient per year, while the United States lives with 10,000? Are these disparities inevitable, or are they constructed, and what can be done about them? So that's a brief overview of the book, but I'm really grateful you guys are here, and looking forward to the Q&A.
I do encourage you to submit your questions in the Q&A if you would like to. We only have one so far, and it came in early, but it's a good point to get into because I'm sure people are thinking about this anyway. Foreign aid became increasingly important in the kind of the post-colonial era for the budgets of many African countries. And we have a question from Sahida Ahmed, which says, have you included foreign aid for health in your calculation of per capita health spending? And more broadly, how does foreign aid skew what healthcare dollars are spent on and how that's changed over time? Now, you gave us a bit of an answer to this with the example of AIDS, But I think you say more about that in the book in terms of the coalition that made that possible, which is a very interesting story. Could you possibly talk about that and then talk more broadly about how aid and healthcare go together?
Yeah, absolutely. Those figures I showed in that graph do include what you might call foreign aid. I mean, the during the colonial period, some of that spending, a lot of that spending came from the UK Treasury. So to the extent that the colonies were not a part of the UK proper, that was foreign aid. And then afterwards, during the 60s and 70s, the UK continued to provide some measure of budgetary support in the initial years after independence. So some of that spending, again, is foreign in nature. But yeah, the AIDS epidemic did show that that healthcare spending can be influenced by some pretty weird coalitions. A lot of the initial spending for HIV in the early 2000s came from the United States President's Emergency Plan for AIDS Relief, for instance, and that was in part spurred by President Bush and his dedication to AIDS spending, which was kind of surprising because, you know, when he was governor of Texas, he could hardly bring himself to say the word AIDS, but in part as a result of evangelical Christian concern in HIV, this became a priority of his foreign policy. And so in 2003, even as he was giving his State of the Union, which is better known for his ultimatum to Saddam Hussein, he was also announcing that he would be spending $15 billion over the next 5 years on HIV and in other countries. So yeah, health. I think one of the things that I learned in researching and writing this book is that, you know, you never know where the money's going to come from. You never know what's going to impact healthcare spending, and there's a lot more to be said than just that. You know, this is just an inevitability.
So Saeed is on a roll here. He's got a follow-up, and I think it's worth asking, so I'm going to bring it in now. Just a small reminder that Mbeki was president of South Africa in 2005, and he largely denied that HIV was causing AIDS, with the Treatment Action Committee suing the government for access to ARVs. Did that period have any implications for Malawi?
Yeah, that was a crazy episode. I mean, so I talked about Nelson Mandela's presidency, but then after that, Thabo Mbeki came to power, and he had all sorts of interesting and destructive ideas about AIDS, and turned his attention largely away from it. As a result, I actually met Zaki Akhmat during that time, and he had turned his protests from Al Gore to Thabo Mbeki. So that, you know, that had a huge impact within South Africa, but largely as a result of the work that had been done in the years prior. You saw an efflorescence of attention to AIDS more globally, and as a result, Malawi finally got some measure of support to address its AIDS epidemic. So that was actually a more hopeful time in Malawi as AIDS treatment was ramping up during that period.
So we've got some other good questions coming in, but they head in different directions. I want to stay on one point for a moment, though. Your central claim, which I very much agree with and I'm sympathetic to, that things could have been other. If there is a central claim to the social construction claim, it didn't have to be this way. The constraints are not just more malleable, they're often not there, or they're caused by things which are misidentified. And to me, one of the most powerful examples is one of the ones that you talked about in the book, which is the absurdity of this railway, which is the brainchild of a Belgian financier who has connections with the British government, who gets the Treasury to float the loan, which then becomes Nyasaland's national debt, which they then pay back for 30 years. And this crook basically makes 6% for 25 years off of it. I mean, of course you then say, well, there's no money for healthcare because they're poor. Well, no, they're poor because 40% of their budget is going on service in a railway, which is basically a con job. So that's a really clear example. But the HIV one, I think, is a little bit more problematic in the sense that it seems that there were constraints. You're in the post-colonial space, you're in the post-Banda space. There's a real health emergency. There is public awareness. And it's really external cash that makes the difference. So that seems to be a case of there really is more constraints. And if you didn't get that money from outside, then it would have been worse. How do you reconcile those 2 points? Do we need to reconcile those 2 points?
Yeah, absolutely. I mean, I think part of the problem with the way we talk about healthcare is that we forget that we should be thinking internationally. We should be thinking globally. And if we constrain our thought and our understanding of the availability of resources to the bounds of the country, to what is available within Malawi at any given time, then of course scarcity comes to seem inevitable. But that is to forget the history of international exactions. That's to forget the history of colonization. That's to forget that, you know, these histories have always been linked. I mean, even if you look more recently, the UN has started to put out more details about illicit financial flows internationally, where due to tax dodging and other causes, there's huge flows out of countries like Malawi, even as there's pretty minuscule flows of foreign aid into it. So if we constrain our understanding to, you know, what's available in Malawi, what's available from their customs duties, what's available from their income taxes, then yeah, you know, healthcare spending is going to seem inevitably low. But I think the example of the railway loan shows you that, you know, it's always an international story. It's always more than just Malawi. You have to look outside. If you don't look to this kind of shadowy figure of Libert Uri, then you don't understand why Malawi only spent so little for the majority of the early part of the 20th century. And if you fail to do that today, then you'll do the same.
So this is an appropriate moment then to bring in Michael Barthman's question. Can you compare and contrast the healthcare disparities you see here in the US and Rhode Island with what you studied in Malawi?
Yeah, I guess I'm always brought back to this moment when I was in college, and we were sitting around, you know, this was a seminar room that, you know, you guys might have some understanding of this if you've taken a public health class. We were sitting in a seminar room. It was at Harvard, and there was a beautiful wooden table. It cost about $10,000, we were told, of ebony. And we were all sitting around it, and we were, you know, the sons and daughters of financiers and doctors and lawyers and whoever else sends their kids to Harvard. And we were told that it was our job to decide, you know, what we should spend money on in developing countries. Would we spend money on vaccines? Would we spend money on basic medical interventions? Would we spend money on sanitation? We had to make the choice. We had to make those tough choices. And it's something I came to learn that Jim Kim, who became the head of the World Bank, called public health machismo, this idea that someone has to decide who lives and who dies. And this kind of this scarcity related thinking happens all the time in our own healthcare system too. I mean, I work in an emergency department where there's only so much time, only so many resources. We have to make triage decisions. But what is it that causes people to go without health insurance? What is it that causes people to go without basic medical care? What is it that causes people to go without basic money to live their lives, especially now as so many people are losing their jobs? This is the kind of scarcity related healthcare thinking that Malawians live with every day. They've lived with for centuries. And while it seems somewhat inevitable in Malawi, I challenge the idea in the book that it is. I mean, if it's not inevitable there, then certainly it shouldn't be inevitable here in one of the richest countries in the world. So I think by challenging the inevitability of scarcity in a place like Malawi, we can come to see it as the lie that it is in Rhode Island in the United States, and look closer at what is actually driving these scarcities.
So Samantha Greenman asks, the drop in price of AIDS drugs from 10,000 to 931 that you showed in one of your slides was quite remarkable. Can you discuss the role of pharmaceutical companies in scarcity and access to drugs? And what do you think we can do to combat this issue in the future? Yeah,
thanks, Sammy. That's my sister-in-law right there.
Okay, loaded family question. That's out.
Yeah, let's talk about it Thanksgiving. So yeah, the pharmaceutical companies had a lot to do with this, right? They in the late 90s, that lawsuit was being brought by 30 pharmaceutical companies, in which they had convinced the U.S. government to pressure South Africa with trade sanctions, and eventually the U.S. government dropped the threats after the pharmaceutical companies did, because of bad press, because of people like Zaki Yakmat and Nelson Mandela calling them out on their basically murderous tactics by trying to prevent poor countries from importing generic drugs. They were preventing people from getting access to the life-saving drugs they needed. So the generic pharmaceutical companies in India were producing these drugs at lower cost. The brand name pharmaceutical companies, the ones that we're more familiar with here in the United States, they were the ones pushing for these trade sanctions. So it shows you that the pharmaceutical companies are like an integral part of this international system that makes it hard sometimes for poor countries to get access to drugs, but also that they're susceptible. They're susceptible to public pressure, and that they don't want to have a black eye in the media. They weren't going to make much money from poor countries anyway. I mean, they were selling on a very minimal amount of these drugs in poor countries, only to the handful of elites who could afford them. So they wouldn't stand to lose all that much money at all if they just handed it over to generics and took a small portion of royalties as a result of allowing them to produce, and which is what they did. So the companies that make these drugs here in the United States, Gilead and all these other companies, they're making money through some royalties off of the sale in the developing world, but they don't produce directly themselves for it.
I may be misremembering this, but there was two other things going on in that area that were very interesting. The drug companies were worried about basically people round tripping the product. So you could go there and basically buy it all up very, very cheap and then bring it back to the US and undercut their core market. So there was this one, right? Mm-hmm. And then later on, there was the whole thing with Brazil and antiretrovirals, where they actually took them to the WTO. And much to the chagrin of the United States that set up the WTO because it loves free trade, basically they found against the United States. So essentially the appellate body said, no, you can't do this kind of stuff. That may be one of the reasons why the US is somewhat turned against the WTO, because it turns out it doesn't really back up big pharma all the time. It's something interesting to consider.
Yeah.
Go ahead.
Yeah, I think even the WTO has this like clause that says that in the setting of a public health emergency, which can be declared by any country, that these rules that would normally govern the international systems don't apply, and that you can start to import generic drugs from abroad. So yeah, the WTO itself like allows for some exclusions that countries like Brazil have made use of.
As a question here from Krishna Prabhu, I remember seeing there's somebody else no doubt. I remember seeing some studies that tried to tease out whether foreign aid for health spending displaced funds that would otherwise be spent by governments themselves on health spending. Was this true for Malawi during this influx of recent global health funding? Before you answer that, I have to say that's incredible. That's what's generally called the crowding out hypothesis in economics. So you're in the middle of a recession. If the government spends, it's going to crowd out the private sector. But if the private sector was spending, there wouldn't be a recession, right? The argument makes no sense. Mm-hmm. Is there actually an equivalent of that in public health, an actual crowding out hypothesis?
I think this is one of those things that's a little contingent on the moment and the leadership. I guess it's a little perhaps out of fashion in international political economy to say that like some of these things are determined by individual personalities, but at least in Malawi's history, they were. I mean, Banda, when he was president for life between the 60s and the 90s, he pretty much did use a crowding out. I mean, he was trying to draw in foreign aid from abroad in order to allow himself to spend more money domestically on things like private palaces. But more recently, you've had presidents in Malawi like Joyce Banda, Malawi's first and only female president, who was president from 2013 to 2015, who made maternal health and lowering maternal mortality rates a huge priority of her rule, and she ended up spending way more on healthcare than had been done before. Malawi basically reached the goal that had been set by the Abuja Declaration to spend at least 15% of domestic resources on healthcare, that very few African countries have reached, even as they were getting more foreign aid for health. So there's no reason why it has to crowd it out, but individual personalities, particular political circumstances do help determine this.
But in a sense, that's a good case for your argument, your broader argument, in the sense that crowding out is presented as a constraint. It's a natural phenomenon. And then when that fails, it then becomes, in the first example, if we do it by aid, they won't spend it, which implies it was there already. But the Banda one is fascinating because I will go to Portugal and basically get leverage so I can just divert the money that would have been spent into palace building. Mm-hmm. And this really is a great example of why the constraints really are political at base. Anything on that, or will I?
Yeah, no, absolutely. I mean, I think, but I mean, a lot of these examples in the book, and I get into some of them, but not all of them, have to do with, the politics of the moment really do a lot to determine what happens. I mean, during the late 40s, one of the examples is the UK comes to be ruled by the Labour Party. This was like the birth of the NHS in the UK, and in some ways, it seems like it would be a great moment for healthcare spending in Malawi. Even the new government said this was the end of imperialism as we know it. This was the time when you'd see this efflorescence of colonial development happening. This is what they promised. This was their reason for continued colonial rule. They said, we're not going to grant you independence, but know that change is here. But in fact, what happened was that there was very little in the way of new healthcare spending in Malawi. And some of the debates within the Labour Party were about things like, oh, well, if we spend all the money on healthcare in Malawi, then we're not going to be in power anymore because domestic audiences will think that we're just spending it all on poor foreigners or poor colonized populations. And so if we want to stay in power, we have to, spend money domestically and not on the colonies. Kind of similar rhetoric to what you hear about immigration today. Like there's all these echoes in domestic politics in the UK. So yeah, the politics of the moment have a ton to do with what's available on the ground.
And what was ironic about that period as well, it's a great example in the book, and I couldn't help but think at the time from my own knowledge of that period, the British Labour government that came in 45 constantly challenged the notion of constraints. And even though there really were constraints, I mean, they come off an incredibly expensive war, they were virtually out of cash, the pound was tanking, it was not a great time. But nonetheless, that's precisely when they nationalised industries. That's when they built the welfare state. That's when they did the NHS. Yeah. So in that most constrained moment was the moment when they actually did the most, thereby giving lie to it. But then when it comes to the colonies, as you say, they talk a very good game of the new imperialism being different from not new imperialism, the new colonialism being different from the old. Well, that was a Freudian slip. The new colonialism being different from the old. But in fact, basically, it's exactly the same stuff. They also had a brilliant linguistic twist that you point out in the book, which was, what did they call it again? Traditional security or something?
Yeah. Traditional social security.
Right. What was that?
Yeah, this is the idea that that Malawi is different, right? That poor countries are different. That in industrialized countries like the UK and the US, we need to have government-provided social security, government-provided pensions. So, the things that we think of today as social security, Medicare in the United States. But in poor countries, people could rely on their families and their villages for social security. And to be honest, when I was in Malawi, people did rely on their family and on their villages. But if you want to talk about scarcity, those are settings of scarcity, especially in rural Malawi. There's only so much to go around. There's only so much support to be provided. And if people want to be able to build up any sort of wealth, any sort of security for themselves, then having to part with their wealth every time anyone in their family or anyone in their village becomes sick. That's a formula for disaster for all. So this idea that there is a traditional social security was a crutch that governments have relied on for decades. The colonial governments relied on it for decades to justify these claims of scarcity. This rhetoric of scarcity, and why it had to exist, and why it wasn't so bad after all that Malawi didn't have a good healthcare system. That's one of the focuses of the book too. There was all sorts of reasons why Malawi couldn't spend more. There's Malthusian reasons, right? If we spent more on healthcare, then people would just breed more, and then they'd be in the same place they were before. All these logics of why more shouldn't or couldn't be spent were super common, and you still hear echoes of them today.
One of the ones that you see early in the period, in the colonial period, is the sort of the natives don't understand modern medicine type stuff. And what you show in the book is that's complete nonsense. What they understood was the therapeutics of the periods from the 1900s to the 1930s simply didn't work. They were all pain and no gain. The story you tell of the one for syphilis is particularly terrifying. But then what happens in the 50s and 60s, they get sulfur drugs and all this sort of stuff, and stuff actually works. And that's when you see that huge uptake, because stuff actually works. And you call them, I forget what you call the Malawians at that point, kind of like grassroots empiricists or something like that. You have a good phrase for it. Can you talk about that?
Yeah, absolutely. I mean, there's all these, you see it today in global health too, right? That there's all this focus on sensitization and getting people to understand, rational use of medicines. But looking at Malawian history, you see that people started coming to healthcare centers when they could be cured of disease, when they were promised more than palliation or drugs that honestly, like you said, cause more harm than good. I mean, some of the drugs that were being used for sleeping sickness, syphilis in the 1910s, 1920s just led to blindness and sometimes death. Like these were toxic agents, and people knew it. People would, run away from the surgeons when they were offered surgery. And the same thing happened during the AIDS pandemic. A lot of people would write of their own work as doctors or nurses as being, I didn't sign up for this in order to just preside over the deaths of my patients. I want to be able to provide effective care. So when these drugs became available, at least for certain ailments, syphilis, malaria in the 1950s and 1960s, people came and they came in droves, and they said that that's what they were coming for. So there's a lot of great research in anthropology about this, but I think we could use a lot more of this understanding of the empiricism of our patients in, certainly in Malawi, but also in the US, when we take care of patients and they start to not show up. Perhaps we should understand what their logics are as well.
So we're getting close to closing time. We've got a couple of good questions, which are much more kind of biographical and personal. I want to leave those to the very end for you to end on those. But Saeed is back. Hello again, Saeed. And he has another good question. So I want this to be the last substantive question, and we'll move into this. So he says, a number of critics of PEPFAR, you'll need to tell me what PEPFAR is, and global health programs more generally call global health the new colonialism, with donor agencies setting the agenda for countries like Malawi, often over the objection of recipient governments. Do you agree with this? Is this a fair or an unfair characterization?
Yeah, there's been a lot about this. It's a great question. Again, beginning in the early 2000s when PEPFAR came out, there were all sorts of stringent regulations about what the money could be used for. Initially, the money had to be spent on brand name drugs, the expensive brand name drugs. Education about prevention had to focus on abstinence. You see the echoes of the Christian right in so much of what PEPFAR was dictating early on. Some of those regulations have fallen by the wayside in the years since, but there's still a lot of dictates from the US and from the EU about how their money can and should be spent, and less control on the ground. And so you'll see, relatively good spending, it's all relative, but relatively good spending on AIDS and less on things like maternal mortality. So in the hospitals, you'll see women die in obstructed labor, and innocent die for lack, or not die, sorry, the innocent loses leg for lack of a vascular surgeon, even as people are being treated for HIV. And then what that leads to is even more scarcity talk. Like, oh, so you'll see articles in the New England Journal, like one I mentioned in the book, where discussion is, well, shouldn't we shift some of these resources from AIDS to these other causes? I mean, it's much more rational, much more utilitarian to focus perhaps on vaccines and latrines than to focus on HIV, when in fact we're still not spending anything, right? So there's all this new scarcity talk as a result of these kind of lopsided spending priorities, when in fact what it shows us is that much more is possible, and that hundreds of thousands of more lives could be saved if we just cared a little more.
And recognize constraints for what they are, rather than shifting politics. Yeah. So I'm going to close with two questions for the price of one. One from Maggie, who says, Luke, are you considering extending your work to another location, or are you going to get deeper into Malawi? And then finally, I'm scrolling up here. Where are we? Robert Shar asks, how long were you able to spend in Malawi doing your research? So just give us a little bit about sort of, where you were and where you're going now that you've done this. What's next, having done this research and having written this book?
Yeah, thanks for those questions. The time I spent in Malawi, I spent probably a total of about a year there in total over the course of 5 trips. Some of it was in the archives in the old capital city of Zomba. Some of it was at this lakeshore village. I showed you a picture at the beginning, and in living in the homes of people who I was following and getting to know. Some of it was in the UK, in Scotland, maybe close to your own heart, learning a little more about the colonial history and the missionary history of the country, where a lot of the records from Malawi are still held. Yeah,
I couldn't help but notice the name Blantyre.
Yeah, Blantyre, the name of the old capital city, of course, drawn from the city.
Outside of Glasgow, absolutely. And the missionaries are all Scots. I mean, I noticed this early in the book. There's the whole sort of Presbyterian missionary link. Literally Dr. Livingston, I presume, shows up in this story early on.
Yeah, that's where he set up his one of his first missions. So the past and the present, absolutely. So that's where I spent a lot of my time. Today, I'm a little constrained, both by residency and by a pandemic, in my ability to travel back to Malawi. I do hope to work and study there and continue to write on it in the future. These days, I'm working on a history of debt, of hospital debts that are taken on by patients, and the aggressive tactics that have been used to recover those debts in U.S. hospitals. So that's my current project. I think it involves some of the same questions, some of the same concerns, but obviously in a different place. But yeah, I definitely do hope to go back. It's a place I've definitely fallen in love with.
Excellent. Well, we can talk about this afterwards. And I got a note from Robert Shar, said, I would like to speak with Luke. We own Malawi LafuHospital.org in Blantyre and are one of the most active investors in Malawi. I asked him to send me his email, and then I'll hook you guys up.
Absolutely.
So it continues. That's it. The link. Well, you're going back whether you like it or not. I think Robert has plans for you.
All right. Can't wait.
Okay, I think that's a good place to end. It's been an excellent discussion. I want to thank you for doing this, and also for writing such an excellent book. I encourage everyone who's on the call to read it. And I think we'll take it from there.
Thanks so much for coming, and thanks again, Mark, for having this.
Excellent. Best regards to everyone. We have another talk coming up, not until December, but you'll hear about it then. Theorio Francus, talking about climate and political resistance. Excellent stuff. Okay, bye-bye.